all. This is Dr. Mobeen Syed from DrBeen.com. Welcome to one more show. So, once again, today we have a rock star team with us. We have Dr. Bruce Patterson and his team. Dr. Bruce Patterson, welcome. Tell us a little bit about yourself and your work.
Thank you, Dr. Bean. It's a pleasure to be back. It's been quite some time, but I'm here. I'm the CEO of IncelDX. We've been working on COVID since January of 2020, so now on to 2 years, and working on long COVID for the better part of a year and a half. So it's been quite an exciting journey, and we want to share with you some of our new data that's coming out in two papers in the next week or two.
Awesome. Thank you very much. And for the cool beans, please, a couple of things. One, I'm going to show you some references and papers for the context of this discussion. Secondly, if you have any questions, can you please hold on to those questions for some more time? Once we have gone through the basic mechanisms that we want to discuss and some outcomes that we want to discuss, then we will open it up to the questions as well. If you have a question that you place out now, it would scroll up and I'll lose it. So please hold on to your questions. So with this, with your permission, Dr. Patterson, I'm going to start sharing some of this. At the same time, a quick disclaimer. So, Dr. Bean Medical or myself or my YouTube channel has no financial or commercial or any strings attached with Dr. Patterson's work or Dr. Yo's work or Incel's work. For me, the biggest and most important thing is to be able to bring in the mechanisms that are being discovered, researchers who are doing that work, the groundbreaking new things that are happening. That is my interest. There is nothing else. There is no other um, conflicts of interest. So let's start our discussion. Here is an article. This is in the science.org. It says, in rare cases, coronavirus vaccines may cause long COVID-like symptoms. This is 20 January 2022. And if you see here, there is a patient whose story is in this article. I would actually request you to read it. And I want to just quickly, for context purposes, share a few things. So here, there's a patient. Her name is, I believe, Brianna Dressen. So by January 2021, researchers at the National Institute of Health began to hear about such reports and sought to learn more, bringing Brianna Dressen and other affected people to the agency's headquarters for testing and sometimes treatment. So she had an injury after the vaccine. And then they say the patient had temporal association between vaccination and their faltering health, says Avindra Nath, clinical director at the National Institute of Neurological Disorders and Stroke, who has been leading the NIH efforts. The point is that at some point, there were patients who are contacting NIH and talking about injuries after the vaccine. So NIH became, you know, they started working with them. And finally, they said NIH communications with patients faded by late 2021, though Nath says the work continues behind the scenes. So at the end of the day, I think what it is that there needed to be some research done to understand what is happening after the vaccines. So here we have Dr. Bruce Patterson and his team, and there are so many other researchers as well who are working on it. And I have shared some of those researches. So here, Dr. Bruce Patterson and his team's work, immune-based predictions of COVID-19 severity and chronic decoded using machine learning, chronicity decoded using machine learning. This was 28 June 2021. Then here is another article, 10 January 2022, persistence of SARS-CoV-2 S1 protein in CD16 plus monocytes in post-acute sequelae of COVID-19 up to 15 months post-infection. The point is, there is a problem. There is lingering symptoms that could occur after COVID or even after vaccine as well. So once again, with this long background, Dr. Patterson, welcome. Tell us, I think you have some more information to share with the cool beans here that may be coming up soon. So can you please tell us a little more about that?
Yes, I mean we were intrigued about that article in the Science magazine and some of the beginnings of our hints that there are symptoms, obviously, in patients who received a vaccine months after they received the vaccine, and frankly, we had been working on it for the better part of 6 months and have seen hundreds of patients who have these long COVID like symptoms or PASC like symptoms post vaccine with no evidence of prior infection by COVID. And were seemingly well. And then, about 3 months, just like long COVID, 3 to 6 months, started experiencing almost identical symptoms to patients with COVID long hauler symptoms. So, and that's what our new study is all about that we're about to release in the next week or so. And we thought it was important, given this suggestion by Science Magazine, that we actually showed some data as to what we found and what we think might be the cause of these symptoms post vaccination.
Got it. And if I can just take 1 minute and share with the audience here, within my own family, two members who are here, one my niece, young woman, and the other one is my wife. They both, after the vaccine, developed symptoms which would not go away. And my niece was quite horrified, 23 years old, looking forward to a great life, and all of a sudden, she cannot focus, she cannot concentrate, she cannot look at things, she works in computers, cannot look at screens, and so on. So there are lots of neurological symptoms she had. And she suffered through them because she actually did not know that I had been working on I Recover. Plus, there are teams like IncelDX, Dr. Bruce Patterson's team, who are working on this, and I'm sure there are more as well. So one day she talked with my wife, and my wife told her that she should reach out to me, and then finally, um, she tried I Recover. She became okay. Then she became refractory to, she had a relapse. She went back to normal activities and had a relapse about a month later. Then I Recover did not work very well. Then I requested Dr. Yo to get us connected to their team. And then one of the doctors from Patterson Group, I think he started working with her, and now she is 99% good. She called me a few days ago and said, sometimes if I exert a lot, I feel that I have some confusion, but I'm able to just go through that and continue to do my work. And the second is my wife. And as private as she is, and she has always requested me to share less, but this is one area where I got her permission to share some, and that is that she had developed Bell's palsy and a twitch in her eye and lips. And now, after talking with one of the doctors in Dr. Bruce Patterson's group and starting her medication, she is once again, she's 99% as well. For example, this issue was continuous with her for weeks and weeks. And now, in 1 week, she said yesterday that, hey, I feel a little twitch in my lower lip. And that is how rare it has started to become for her, which we, of course, are quite grateful. So these are some stories from my own home. So going back to Dr. Patterson, so you have a couple of new publications, data, new studies that are coming out. Please tell us more about them.
Yeah, I think first of all, I'm very pleased about the response within your family, Dr. Bean, and what I'm about to present is what we found when we looked at these individuals post vaccine long haulers, and again, we're all vaccinated, we're all we're all just showing the data and what the data means in terms of some of the individuals having these side effects. But here's the first figure from our paper where we actually show the symptoms, if you look at them by vaccine, are very, very familiar if you know the symptoms of COVID long haulers. Neuropathies, brain fog, headache, dizziness, fatigue is huge. So this chart looks almost identical to the paper that was published by us last week on COVID long haulers. Next slide. Then what we did is we looked into the individual cytokines that are in our cytokine panel that's run by reference labs across the United States and now recently launched by reference labs in the EU and the UK. And what we found was there was statistically significant elevations in CCL5 or RANTES, SCD40 ligand, which is a platelet activation marker, which is very critical both in COVID long haulers and in post-vaccination long haulers, because we were the first to identify about a year and a half ago this setup for clotting, and everybody's talking about microclots now. Well, the setup is on inflamed endothelium and endotheliitis, which we'll talk about in a moment. You have platelets bound. The platelets become activated. They attract other clotting cascade components. They produce soluble CD40 ligand and CCL5. So that was key in both COVID long haulers and in post-vaccination long haulers. Now, what we found in post-vaccination long haulers that was slightly different was elevations in interleukin 6, which is found in acute COVID, and elevations of interleukin 8, both of which are statistically significant. Interleukin 8 was not elevated in COVID long haulers, and I'll explain the significance of that in a moment on the next slide. Next slide. Our crack bioinformatics, machine learning, and AI team was able to overlay post-vaccination long haulers immune profile on top of COVID long haulers, which you see in yellow, severe acute COVID, which you see in light green on the vertical axis, and mild to moderate acute COVID, which you see in the lower left-hand corner in dark blue on this figure. And what you'll notice is that the post-vaccination long haulers are basically in the same pattern as long haulers, with slightly less inflammation on the severity score. But really, the severity score has interleukin 8 as a denominator. So the score is reduced because in post-vaccination long haulers, they have high interleukin 8 relative to COVID long haulers. But for all intents and purposes, AI called these post-vaccination long haulers or PASC. Next slide.
Got it. So just to my assessment, so not only you have been able to observe or have patients that have post-vaccine, as you're saying, long hauling, you were able to do the markers and see the inflammation happening in them as well.
And model it so that we knew how to treat it, which we'll get to in a moment. And so that led to the next question, which is almost identical to what we published in COVID long haulers, and that is the S1 persistence, the S1 protein persistence in the monocyte white blood cells driving post-vaccination long haulers, just like it's driving COVID long haulers. And indeed, when we looked at these cells by two methods, flow cytometry, and more importantly, the very, very specific mass spectrometry, we found that the S1 protein was retained months and months and months after vaccination in the non-classical and intermediate monocytes. And of course, go ahead.
My apologies. So you had seen S1 holding on into monocytes in COVID. You're
Correct.
seeing that with the vaccine as well.
That's right. And, this, it's almost an unfortunate experiment, which shows that I think we were right on the track of the underlying mechanism in COVID long haulers, because here's an instance where basically you're injected with just S1 protein and not the entire virus, and it's causing the same symptoms, it's causing the same immune profile. And in fact, we see the same retention of S1 protein in monocytes as we did in COVID long haulers that received the S1 from the virus itself.
And when is this study coming out?
We will be submitting it next week. It should be out in preprint in the next week or two, so everyone can read about it.
Got it.
In this slide, again, we use the very sophisticated mass spectrometry to confirm that these cells, when we lyse these cells and sequence the protein, that protein, that S1 protein, was indeed identical to our controls, which are basically store-bought S1 protein. However, in the next slide, we show that not only did we find S1 protein, but we found some S2 peptides, probably due to the fact that the vaccines are the entire S gene, and which make the entire S protein. And then we also found some potential mutant peptides in S1 that we don't know what the significance is in these individuals, but it's certainly something that we'll be looking into, and something that has extreme importance in terms of obviously the S1 mutations in Omicron, when we start seeing long haulers in Omicron, which we expect.
Got it. So I think that, just thinking aloud, I should change this talk's title to S1 protein after vaccine in the monocytes as well. I have a question for you. The S2, in this case, you saw it, but you didn't see that with COVID.
Right. We did not. And, it may be because we've improved our detection methodology. We're looking into that right now, but we did find it in this particular group of patients.
Got it. And the second question I have is, so I am still kind of enamored by this idea that monocytes are holding on to the S1 for months after months.
Mm-hmm.
So why are they doing it? Monocytes are supposed to die away and clear away. Why are they living, and why do they continue to carry on with S1?
That's such a great question. And what's very interesting about the non-classical monocytes is their sole job is to patrol the blood vessels. And again, bringing the S1 protein close to the blood vessels and causing inflammation in the blood vessels is a result, we think, obviously, of the ability of these non-classical monocytes to go all over the body, get through the blood-brain barrier. And we now found data that's in the new paper. Of course, we already talked about the fact that these cells are mobilized by exercise, which may be one of the reasons why exercise causes a worsening of the fatigue and symptoms in both COVID long haulers and post-vaccination long haulers. But there's also data that shows that stress mobilizes these cells and can obviously increase the symptoms in both COVID long haulers and post-vaccination long haulers. But the reason we think that these cells are long-lived is that under pathologic conditions, or in conditions where they've phagocytized or gobbled foreign proteins, that it sidetracks their senescence program. And so they don't undergo apoptosis like they normally would, and they live a much different lifespan than they would normally in a non-pathologic condition.
That is actually very interesting, because this is what I wanted to understand, and thank you very much. Ideally, the monocytes are supposed to go away, so their apoptosis, their process of dying naturally, looks like that gets disrupted by
Mm.
somehow, may I use the word toxicity, some toxicity by the spike. causes monocyte to start living longer.
or just processing and presenting foreign antigen, which is part of what monocytes do.
Hmm. But monocyte process and present many other foreign antigens too.
They do, and in fact, the same mechanism we believe is at play, and it's been actually published at play in post Lyme, where they actually carry the Borrelia cell wall in these cells, intermediate and non-classical monocytes for a long period of time, maybe even years. And we're using the same approach and some of the same treatments to treat patients with post Lyme with really good success so far.
So that means post Lyme management techniques can help here, and any new management techniques here can help there as well.
That's what we're working on right now, and we're doing a lot of proteomics on the post Lyme patients to really get into these monocytes and see if they carry Borrelia peptidoglycan and other components of Borrelia and Bartonella and some of the other agents that cause Lyme and what's called PTLD or post-treatment Lyme disease. And like I said, we've used the combination of drugs that we're going to show in the next segment in post Lyme with remarkable success and frankly unexpected success.
That's very interesting. So I have a question here from M. Gregory. So the monocytes slow down. Do they slow down or they start living?
Yeah, so there's great, like I said, great literature coming out in our next two papers that show that CCR5 antagonists and statins both inhibit non-classical monocyte binding through the fractalkine receptor and not only binding but accumulation of these cells in the blood vessels. So they've been, there's mechanisms why using CCR5 antagonists and statins, as we'll talk about in the outcome paper that we're about to show, why that's being so effective.
Got it. Thank you. And I have a comment here from John T. Orchard Fire. I'm part of the stories on the website, Real Not Rare Stories there. So many photos. We had lives. This is what really pains me. There are some cool beans who are stuck in the state too. As I said, my own family members, they this as much as we say rare, th- there are lots of people who are suffering through this.
Yes, the absolute numbers are tremendous. I don't know what the prevalence is, what that percentage might be, because so many people have been vaccinated. But it's not uncommon to know people, and obviously, like I said, we probably treated close to 1,000. With as we did with your family, with the combination of drugs that we're going to show in the next segment with success. And I'll say, and we can talk to Dr. Yogendra as well, but I would say the post-vaccination long haulers respond a little bit faster, more completely, and they don't need, they don't have as many confounding factors or other inflammatory markers than what we just showed.
Got it. One more question before we go to the next slide. Um, Luke Belders say, what is the role of, so I'm going to bring you up here. What is the role of interleukin 1B in all of this? Any relation to rantase after IVIG cytokine levels have come down substantially? However, 1B remains high and myopericarditis symptoms persist.
It's a good question. We looked at IL-1B early on, and basically our AI didn't choose IL-1B to be part of our panel because we didn't see many changes in long COVID versus acute COVID. So, there are drugs that will address interleukin 1B. We know the CCR5 antagonists bring down interleukin 1B, and so I think, and of course, in our cohorts, both of COVID long haulers, which are now well over 14,000, and then post vaccination long haulers, which probably is close to 1,000. We are seeing effective response of pericarditis, and we're actually starting to look at some of the patients with myocarditis in the post vaccination group.
Got it. Thank you very much. So, before we go towards the next steps, if I summarize it, there is, after vaccine, a similar S1, S2 protein hanging out in monocyte, disrupting their function, causing inflammation, creating a lot of symptoms that are very similar to long COVID as well. Hopefully, easier um, to treat. My question to you, and again, we can have that discussion during the management side as well. What is the percentage of success? And so, whenever you're ready, if you want me to go to the next screen, I can.
Yeah, I think we've always said that the degree of responsiveness is in the 80s, and as you mentioned with your family, I mean, we are getting some people back to 100%, and there's a lot of, especially in COVID long haulers, there's a lot of comorbidities, and then of course there's a lot of the patients may have had some of the chronic herpes viruses like EBV or CMV. We're hearing a lot about EBV. I think we see it in probably 10 to 20% of our COVID long haulers, and that has to be dealt with. And I would say, all in all, the group of post vaccination long haulers are a healthier group without as many comorbidities, and that may be part of the reason why they respond so effectively.
Got it. Thank you very much. So, do we move to the management
Yes,
approach? Okay, excellent. And is that something that is also coming out as a paper, some outcomes?
absolutely. So we were so excited. I tweeted out that 2022 is going to be devoted to disseminating information about our treatment regimens, and really setting ourselves up for randomized controlled clinical trials. I think what you're seeing here is the first step in that direction. We're doing a case series of about 20, 25 patients. And then we're going to follow that up with, analyzing hundreds of patients in our cohort in the same manner. What we wanted to do is get this data together to see the correlates of responsiveness in patients who really respond, and the correlates of symptom response, and how that correlates with response to the biomarkers. So the next study you're going to show is a validation of the biomarkers in terms of symptom prediction and response to therapy, and how that correlates with the response of symptoms. We're going to take that data using FDA, FDA mandated symptom scores, and use that for our trial design and our long COVID clinical trials, with the drugs that we're going to talk about. So I think that's the setup. And yes, we fully intended for both of these papers to come out at the same time, since the symptoms are similar, the mechanisms are similar, and of course the treatments are similar.
Got it. Thank you very much. So, ready for the next?
We are.
Do we bring in some surprise guest?
Dare to bring in Dr. Yogendra. Yes, we will.
Here we
Dr.
are. So,
Bean.
Dr. Yo, welcome.
Thanks, Dr. Bean. I thought I was banned from your show, but I'm glad you guys let me in. Guess Bruce must have put in a good
So for
word.
today, you can come in.
Great, thank you.
So, Dr. Yo, tell us a little bit about the outcomes approach. What are you going to discuss with us? And is that something that is also becoming a study and getting published?
Yeah. So as Dr. Patterson mentioned, 2022 is about outcomes because we spent the first 18 months or maybe the last 2 years really now looking at the mechanisms, and the first two papers looked at, the first one was the finding the inflammatory markers, but more importantly, I think the second paper was much more critical because it allowed us to understand where those inflammatory markers were coming from. So now we've treated thousands of patients, and one of the things with our program is when we set everything up, we had a debate and a discussion. Do we let patients in that do they need to have a positive COVID test? And we made a decision as a group that we would let patients into the program regardless of if they had COVID, if they had a suspected COVID, symptoms of COVID, because unfortunately, patients between January and around July of 2020 didn't have access to testing, and or they had poor, or if they had access, it was to poor quality tests. And do we punish them? Do we exclude those patients? Do we gaslight those patients? It's not their fault, and we made a decision we would allow them into the program. And there are pros and cons behind that. The pros obviously is we're a patient centric group. We are all physicians, we're all MDs and DOs in our team, and we take care of people. And for us to tell patients, well, you don't fit a certain criteria or you XYZ, we didn't want to do that. And we welcome all those patients in. You could tell me that you were on a plane in April 2022 and you got a cold and you think it's COVID. Okay, we'll work with you. We'll work with your doctors. But the cons behind that, and sort of when you're looking at it from a study perspective, is quite frankly, some of these patients never had COVID, or there were some other underlying conditions that maybe got exacerbated with COVID, and we're not dealing purely with a long COVID situation, as Dr. Patterson mentioned. And so when we decided now when we're going to study these patients, we had to pull out ones that what we would call like a pure sample that we can control certain variables. And we looked at patients that had a positive COVID test and they had inflammatory markers, because there is a cohort of patients that had a positive COVID test and they have no inflammatory markers. And it's very interesting because when we talk to those patients, a lot of their symptoms start during active acute infection, meaning that there is something that's going on during the active phase of infection where there's a tissue damage that is not really immune mediated. I think our cohort of patients, a majority of them are this immune mediated, this S1 driven pathology, but we have to acknowledge there is another group of patients that I couldn't tell you the number or the percentage, but they do exist.
Well, I
So
think I just to interject, I think one of the most important things with this new study on predicting who might get long COVID, I found it very interesting because we know from the first paper I published on acute COVID, one of the telltale signs was this extreme decrease in CD8 T cells. And what that did was it reactivated these chronic herpes viruses, EBV, which of course was one of the parameters in this new study on how to predict who has long COVID. But with EBV reactivation and all the things that come along that, my question on this new study was, are they really long COVID, or is this ME/CFS, which actually has very similar symptoms? Next week, I'll be talking at the post-infectious immune conference at George Washington University, and showing the immune profiles in ME/CFS. And my concern about this new study on predicting who's going to get long COVID is it actually predicting this subset of patients who really have underlying ME/CFS and it's being reactivated by low CD8s. So in this current study, we were really trying to get a pure population of people with no comorbidities, no history of anything else in terms of our entry criteria, to look at a pure population, to look at correlations between symptom recovery and biomarker recovery.
That is very interesting. So it's not unmasking of something else. It's not presence of something else. It is a healthy individual, as much as we can tell, and then getting this disorder.
Correct. And again, when we do our randomized clinical trial, I mean, we're going to have very strict entry criteria because it's such a heterogeneous disease. And
Mhm.
if you don't match your controls to your treatment population, um, you're not going to have a successful trial. So I think coming up with the strategy, which we did in this paper, is going to be very, very useful in our clinical trial design for our randomized placebo-controlled trial.
Got it. Thank you very much. Yo, before I go back to you, there's a question. Meeple Art says, is it all vaccines? Does Bruce think Novavax will do the same?
I'm not a soothsayer, so I don't really know. I focus on data, and we only looked at the three major vaccines, and then we had I think a patient or two with AstraZeneca, but I wouldn't want to make any predictions on Novavax without seeing data. I mean, everything we do is data, 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 data. We try not to get involved in a lot of the side conversations, and really focus on
Makes
what the
sense. Makes
data
sense.
showing us. So.
Makes sense. Dr. Yo, back to you.
Yeah, no. So yeah, so when we put together, as Dr. Patterson mentioned, we've had a very strict criteria. We one of the things again when we start talking about randomized trials, and this is one of the challenges in chronic diseases, is if you don't know what you're studying, you can't do a trial. And this is why with the MECFS, chronic Lyme, we have these trials and data, and then there's nothing really, we don't really sometimes see the outcomes that we want. And what we wanted to do, we spent the last 18 months, is just clinical observation. As physicians, this is what we're trained to do, is we use our clinical acumen to determine what we're seeing, and to say who's responding, who's not, why, and ask those questions. And what we
So
ended up, sorry, go ahead.
I have a question. So Rima has asked this question, which is really interesting, and it is in my mind as well. Background: when I got COVID a few weeks ago, I actually just cruised through that very, very normally, but I developed tinnitus.
Mm-hmm.
And I am 2 dose Moderna. I hadn't had the booster yet. Got the COVID, generally was fine, even kept doing my daily routine as well for teaching, but had tinnitus, which is now kind of going. If Rima doesn't mind, she developed tinnitus as well. So, have you seen tinnitus as well?
Oh my God, we've seen so much tinnitus, and usually it goes hand in hand with brain fog, because what's in the paper that just got published is the fact that when you have this vascular inflammation, especially from the binding of non-classical monocytes, especially in the brain, what happens? Well, number one, you get increased VEGF. You get increased IL-2, which oddly enough is the numerator of our long hauler index. So that makes sense. But number three, what happens in the brain and the rest of the body for that matter is you get vasodilatation. What does vasodilatation cause? Headache, migraine, and tinnitus. And what does vasodilatation do in the rest of your body? Hot cold insensitivity, which a lot of people talk about. Um, you know, uh, their extremities are cold or their extremities are hot. All of this is due to this broad vasodilatation. What happens when you have, broad vasodilatation? Your blood pressure goes down. What happens when your blood pressure goes down? Your heart rate goes up. Every long hauler and post-vax long hauler talks about their high heart rates, right? So when you relieve the inflammation, you relieve a lot of this. And I'll tell you, the two drugs that we're going to talk about, Moraviroc and Prevestatin, are tinnitus and brain fog busters. And we have a few patients who don't respond, but for I would say the overwhelming majority, we can get rid of brain fog and we can get rid of tinnitus. We actually had one patient whose tinnitus went away in 5 days after therapy, after having it for 6 months.
Got it. Thank you very much. Dr. Yo.
Yeah, so we can. Yeah, if you want to just go into the slides, Dr. Bean, and we can sort of talk about it. I think let's go to the next slide. I think that'll be the. So one of the things that we wanted to do as a group was we've got objective markers. So we talked about especially the first two papers looked at the mechanisms, and we looked at elevations in RANTES and XYZ. But I think more importantly for the patients, and this is the one thing people continuously ask us, is, well, where's the outcomes? How do you know these patients are getting better? How do you measure that? So what we did was we took this cohort of patients that we fulfill the criteria, but which, by the way, we had access to some information from the FDA in terms of some of their criteria that they would be looking for in any future clinical trials. And so we are using some guidelines developed by the FDA in these trials, because what we are hoping to do, or not even hoping, we anticipate in a few weeks to get a randomized trial started using this paper as the framework for the trial. And what we did was we looked at, we took the biomarkers, and then we also looked at patients using subjective scores, using validated scores. One of the challenges with studying long COVID, and quite frankly, even the post-vax group, is it's a heterogeneous disease. It's been described there are over 200 symptoms that have been associated with long COVID. So the question in our minds was, well, how do you study that? How do you put everything into these different categories? And what we did is our group decided that we were going to look at sort of five major symptoms, or sort of five major groups. One would be the cardiac symptoms, respiratory symptoms, fatigue, neurological, and autonomic. And for us, we could take some of the major, maybe the top 20 or 30 symptoms, and sort of study them in these different groups. We looked at, and what we did was we took these validated scales, and these are subjective scales that have been used in clinical practice and have been repeatedly. So we know that whatever, the scores and the responses are going to be accepted in the medical community as validated scales. And the first one on this slide that you see, Dr. Bean, is the modified ranking scale. And this is a scale that looks at neurological insult, especially patients in strokes. And we use this in clinical medicine to, see patients' baseline after an injury, and also, more importantly, any response to rehab or any therapy. And what we did, you can see, and by the way, I should mention, the patients on this cohort were on medications for 6 to 12 weeks. And why is there a variation? Well, some patients, after 6 weeks, they felt completely fine and could come off the medications, whereas others needed 12 weeks. And it could be, quite frankly, whether it's the length of their COVID illness, some other factors that, we just need more studies to understand. So we're looking at a very tight control of these medications. They were on the medications for 6 to 12 weeks. And their response, you can see, is that their Rankin score, which looks at neurological disability. And in this, we included patients having inability to walk without assistance. Their severe or moderate disability is around a 3. So most of the patients had moderate disability, requiring assistance to walk, requiring assistance to do daily activities. Then this also included some of the cognitive issues, the brain fog. Some of them have their neuropathy is so bad that they can't even get out of bed. So those are some of the neurological things we sort of looked with the Rankin score.
So you're talking about post-vaccine. This is not
No,
COVID.
this is
No.
long COVID. This is long COVID patients.
Long COVID.
We should point out, treated with Moraviroc 300 milligrams twice a day, and Previstatin 10 milligrams once a day. So just to be clear on what the treatment protocol was.
Got it.
These are COVID long haulers.
Got it. And I want to share with the audience, with the cool beans here, these are not medical advices. This is not a prescription. Please do not take these drugs, can cause problem. So please don't take them over the counter. Please talk with your doctor. Please contact maybe IncelDX as well. And once again, when I say contact Dr. Bruce and Dr. Yo and their team, I have once again zero commercial interest. This is my interest right now, right in front of you. They are here. They are talking about it with you. That's my interest. Otherwise, there is nothing. But please do not use these medicines on your own. Please be very, very careful. So back to you, Dr. Yo.
And also, just to be clear, IncelDX does not prescribe medication. We make recommendations based on what you're seeing here in terms of biomarkers, and now we know the relationship to symptom recovery. We make recommendations to their primary care physicians who prescribe the medications, because a lot has been written about IncelDX that is incorrect, and we do not prescribe medications.
Yeah.
Got it. And so for my own niece and my wife, it were the doctors who prescribed the medicines. And once again, just to clarify how um, there is no conflict of interest, at my niece and my wife, they paid their fees to the doctors, whatever were their regular fees. They paid for their prescriptions, and they went from there. So very good. Got it. So
Yeah.
what's
So
next?
So, Dr. Beam, yeah. So, what was the interesting thing is the ranking looking at the neurological symptoms in these patients over a course of 6 to 12 weeks. We saw decrease in symptoms. So you can see the score went from roughly about 2.5 on this score to about 1, meaning that we were able to improve a lot of the neurological symptoms and the disability associated with the neurological issues. Very interestingly, we saw 2 markers. And one of the things when we just got this data maybe about 2 weeks ago, and I think Bruce and I were doing virtual high fives and being very excited because what we had been talking about or sort of hypothesizing and theorizing based on the mechanisms, we're now starting to see this clinically. We had said, Bruce has talked about this in the summer of 2021, was he called long COVID. I clearly remember vascular endothelialitis, meaning just an inflammation of the endothelial lining. It's not a very common term we use, but I remember clearly him using that term. And what was very interesting is seeing these biomarkers, the SCD40L, which is a platelet activator, and VEGF, vascular endothelial growth factor, were both statistically significantly elevated. These were the 2 markers that were found by the bioinformatics team. And the CC stands for it's a correlation coefficient. Also know it's sometimes we use R, and it has a positive correlation, meaning that decrease in the symptoms correlated with a decrease in SCD40L and VEGF, suggesting that a lot of the neurological symptoms are driven by vascular inflammation. Now, very interestingly,
That's very interesting. So my apologies. I keep interrupting you. My apologies. But this is important um, that these markers are actually, one is platelet ligand and the other one is vascular endothelial growth factor. These are vessel related problems.
Absolutely. Yeah,
Very
absolutely.
So, the interesting thing, Dr. Bean, the second paper was the CD16 positive monocytes, and you can sort of break them down into sort of 2 subsets: the intermediate and the non-classicals. And the intermediate, the CD16 positive, CD14 positive, they have both expressed CCR5 and fractalkine, and non-classicals express the fractalkine. We found the S1 in both of them, and they both, and we comment on this on the paper that's coming out next week, is that both of them have an affinity to the endothelium, meaning, again, that's what it's known. And, they were HIV reservoirs that were found. I think, Dr. Patterson was involved in a lot of that research, back in the 90s, looking at the HIV reservoir and that as causing the endothelial or vascular inflammation. And we hypothesized that, and we're sort of seeing some of these biomarkers. So those were the 2 things that were associated with the neurological issues, both of them. Now, I want to just talk a little bit about what we talked about in the paper. Our group looked at it, and we're calling it like a monocyte endothelial platelet axis. We think of, when we hear of this drug Monovax, a lot of times people think it's an antiviral or it's an anti-inflammatory. It's an immunomodulator, and we're actually targeting it for the vascular tissue. It's the first thing people hear, Monovax, HIV, is it an antiviral? What's the mechanism? No. In the literature, it's been shown that Monovax has endothelial, it protects the endothelial lining. In patients with atherosclerosis due to HIV and the HIV medications, Monovax is known to be protective. And we'll talk a little bit about that, sort of the mechanism about Monovax, because I think people just focus so much on RANTES, but not understanding there's a downstream effect. I'll let Dr. Patterson comment on that. He's got a lot of
No,
experience with it.
it was amazing how much we found in the atherosclerosis literature on the utility of both CCR5 antagonists and statins in terms of relieving vascular inflammation and relieving this, what we call as a nidus, or a, this center where clots can form, and the fact is that we can do it by drugs, and we don't need, plasmapheresis or, very heavy anticoagulants like Eliquis and some of these drugs where, if you nick your leg, you're in the ICU because you've lost so much blood. It's more subtle than that. And like I said, we learned a lot from the atherosclerosis literature.
Got it.
So, Dr. Bean, if we want to pull up the next validated scale we use. So, no, this is I thought was kind of a very interesting finding, and something I was very excited about these results. Now, Compass 31 is a validated scale that's used to measure autonomic dysfunction. It's used very commonly in the MECFS community and researchers and fibromyalgia community too. And what Compass 31 does, it looks at some of the autonomic dysfunction. It breaks it down into 5 different groups. And very interestingly, we saw very strong p-value. You can see right there, after 6 to 12 weeks of Moravrac, autonomic dysfunction improved. And you can look at the scores. I mean, those are roughly close to 40. Now, this is a scale that goes from 0 to 100. Then that's the scale of the Compass. So someone at 100 would be the highest score, and 0 would be 0, no symptoms. And you can see with very statistically strong data or response. Very interestingly, we saw, again, vascular inflammation taking place, SCD40L, VEGF, and another marker called GM-CSF. Now, here's the interesting thing. SCD40L, or the autonomic dysfunction, and I'm going to include the POTS, the postural orthostatic tachycardia syndrome. A lot of patients have experienced that. There is literature that has suspected the pathophysiology of POTS is endothelial inflammation. And here we are seeing some potential correlation or supporting what's been published in the literature, that you have VEGF and SCD40L with very strong p-values and a positive correlation that decrease the use of Moravrac and statin 6 to 12 weeks decreases autonomic dysfunction, and that's correlating with a decrease in both 2 of the vascular inflammatory markers.
Got it. So, if you give me 1 second, there are 2 or 3 interesting questions that I think if we can provide the answers to, it would help a lot of people. One question is, Misty says, how do you get to be in the study trials?
www.covidlonghaulers.com. We're updating the website. We may include, obviously we do include post-vaccination long haulers, MECFS, post-Lyme, and fibromyalgia. So we're treating all of those conditions. So,
got it. There is a comment, and let me bring Dr. Yo here before he says, hey, where was I? So Rachel says, thank you, IncelDX, for your work supporting us, vaccine injured. I'm participating in your study next Monday and donating my blood. So Rachel, thank you very much. There's a question that I see quite often. Augie says, are your patients making full recovery symptom-free? Thank you.
I mean, that's a big question, since we're treating 5 different related conditions. And the fact is, we're getting people significantly better back to their jobs, back to their daily activities of daily living. There's some element of, deconditioning in patients who have been laid up for 15 months or more. But I would say, it's, these patients are getting, close to where they were pre-COVID. And that's the thing that's most important to us. Do we have patients who don't respond? Yeah, I think, that's true in any, field of medicine. But I would say, the overwhelming majority of patients are responding. And again, it just depends on the patient. It's such a heterogeneous group. And that's why in this study that we're showing data right now, we use very strict entry criteria to make sure that we had a very homogeneous group. And we're going to stick to that for a randomized controlled trial, or else it's just chaos. So
the Dr. Bean, the one with who on the paper that's 6 weeks. We have a couple of 6 weeks that were off the medications, and this group, a lot of them are off the medications or started to taper. They didn't require the full dose of the things that are starting to taper off. The pediatric population, 5 to 6 weeks
Unbelievable.
off the meds.
Yeah.
Off the meds. Just talk to the parents. I
Back,
mean, it's
back to playing hockey, back to figure skating. I had a family with, a kid who was a long hauler and a father. They just went skiing. Okay. I mean, I can't think of, I mean, I said, I don't know what to predict. I don't know what altitude is going to do for your long COVID, but they came back and they're doing well. But yeah, it's the kids where you see, they can't go to school. They can't think. They can't do their homework. They're laid up on the sofa, and the next thing you know, 5 to 6 weeks later, they're back to their figure skating routines. They're playing hockey 3 times a week. They're fishing for marlin. This one kid that I've been treating. So it's remarkable, and of course we've seen a spike in pediatric long COVID cases due to Delta, and we're going to see obviously a spike with Omicron as well.
Got it. There's a question. I'm sorry, Dr. Yo, you were going over the markers and possibly then the management, but these are the questions which I think if they are within this discussion, it would benefit a lot of people. Elaine says, are you treating pulsatile tinnitus?
We don't have anyone who really presents to us with a symptom. They don't come in and say, well, I'm here because I have pulsatile tinnitus, right? It's usually part of, what they've gone through. So I don't really know how to answer that question. When someone comes in with tinnitus, it's usually accompanied by brain fog, and, vice versa. And so, yeah, we treat that as a whole. And that's part of the dysautonomia that we just showed in the COMPASS scale, with highly statistically significant decreases in symptoms. So, I think that's what's so important about the outcome studies is all 5 symptomatic scales that we showed were highly statistically significant after therapy. And, so Ram can go back to going through the scales.
Got it.
Yeah,
Thank you. One more
I also
question.
sorry,
Yes.
Dr. Bean, I just want to mention, there's been some speculation in some of the studies and with some of the researchers of the role of these something called G protein autoantibodies. Now, here's the interesting thing. Both CCR5 and fractalkine receptors are G protein receptors, 7-membrane G protein receptors. So if you're making antibodies against the G protein receptors and what people are talking about, this autoantibody, the hypothesis and what they're testing, it could Monovax and statin by inhibiting those 2 receptors respectively. Are we also targeting the effects of the autoantibodies, and is that another mechanism? That's an interesting question that we were going to bring up in the discussion of the paper. That both of them are the G protein receptor. So obviously more studies to be done, but some interesting questions and some things that we can think about.
Got it. So one more question before we go back to the presentation. Tare tab 123 says, is your patient pool limited to US residents?
No, finally, it's we announced in the fall that we were expanding to the EU and the UK, and through a lab called SynLab. SynLab finished their validation of our panel with the AI. And again, IncellDX does not do any testing. It's reference labs that are doing the testing, and they're regulated. They're under regulatory control. And now we have one of the biggest ones in the world, SynLab in Europe, doing the testing for the EU as we roll out the first 2 countries where we already have patients enrolled and being treated, which is Spain and the UK. That's going to expand to Germany, France, Italy, Mexico, Brazil, etc., because of the reach of this lab that's global. They have labs all over Latin America, South America, Central America, and the EU. So yes, finally, right after the first year, we launched in the EU. So we're very excited about that. It's
Very
not,
good.
it's going to take some time for all that information of how to access that to get disseminated, but we're very excited about it.
And with patient and with physicians that are working with us in Spain and now in the UK, that
Hmm.
we're partnering up and working on a collaborative model like we do here in the US.
Right.
Got it. So one more question, and I'm going to switch back here as well. So Denise says, why a specific parvastatin, or is it any statin?
That's an interesting question, and one we get all the time. Any statin will work, and we've got other patients on atorvastatin, simvastatin, all the other statins. Why did we pick pravastatin? Is more from a theoretical point of view. Moravirac is metabolized by the P450. It's basically a system in the body of how your drug your it's how drugs are metabolized. It's a pathway of metabolism. And what we wanted to do was to, since we are studying these things and we want to understand this, to mitigate any potential risk or drug-drug interactions, we chose pravastatin because it uses glucuronidation, which is another way of metabolizing medications. That's the only thing. But clinically speaking, we haven't seen really any issues with any of the other statins. And also some of the doses, and we'll talk about this in the paper, the doses we chose were all based on FDA studies in the respective diseases. Like in Moravirac, the dose we chose was what the FDA had looked at in terms of in a 96-week, something called a Motivate trial, where they looked at this drug for 96 weeks. So we were very confident that, when you look at the safety of these medications, that we were looking at data, things that are published. And so we were very comfortable with that. And the interesting thing is hundreds and hundreds of doctors in the United States, now in Spain and in the UK and in Canada, also saw this data and were very, very comfortable using that. I also mentioned something about the safety, because we get this question all the time about the safety, because there is the box warning, black box warning of the liver issues, and people get so freaked out. We have not had a single patient had any issues with liver enzymes. But I'll tell you where they get the liver enzymes: statins. We've got a handful of patients that they got elevated liver enzymes, and we said, "Well, what did you take?" It was like 4 or 5 of them out of the thousands. They said, "Oh, we took statins." So that's very interesting. A very common drug that's generic. We prescribe it like water. We see elevations in that. But again, even though those numbers are really low, the patients in our study, what we did was we measured liver enzymes, actually all the labs before, establish a baseline, and then every 2 weeks while they're on treatment. So this way we're able to, be closely monitoring that, mitigate any sort of risk, and we'll comment on that on the paper. I want to, if we can go to the next slide, Dr. Bean, the Compass 31 is looking at the autonomics. Now, this is kind of interesting. So the dyspnea, we used the Medical Research Council breathlessness, or the dyspnea scale. And this is a validated scale. It's been around for clinical practice for 50 or 60 years. And what we did was, one of the symptoms, very common symptoms with long COVID patients and, post-vax, even though we're discussing long COVID. I always say, Dr. Bean, that long COVID patients and the post-vax patients are cousins. Both driven by the S1, but there are some differences. Now, we were very interesting, again, 6 to 12 weeks of Moravirac, we saw a decrease or improvement and a decrease in the MRC breathlessness score. Here's the interesting thing. Again, we're seeing the SCD40L, the statistically significant markers. IL-2 was very interesting for me. I think if people have been following some of the news recently, I think there was a study that came out in the UK a couple of days ago, where some of the researchers found that there's some pulmonary vascular inflammation that they are attributing to the long COVID respiratory problems. And that's something we had hypothesized and we had discussed as a group for a very long time. Interleukin 2, interestingly, is actually implicated, one, as causing asthma like bronchoconstriction in patients. Two, interleukin 2 has been known to cause vascular inflammation, pulmonary vascular, very specific pulmonary vascular inflammation, and increasing vascular permeability. And we will comment on that on the paper too. And very interestingly, Moravrac and statins decrease interleukin-2. This is published in the literature
which
too.
is also the numerator of the long hauler index. So what you're seeing here is this cross-validation of the biomarkers from our first paper, where everyone said, well, it hasn't been validated. Well, now we are validating it with symptom response to medication, and that's extremely satisfying. And shortness of breath is something that I would say most COVID long haulers complain about. So I was really pleased to see this data on the dyspnea scale.
I was surprised by this, Dr. Bean. I was surprised. I mean, we knew patients were, one of the things we see these patients on these video conferencing with their physicians, and we say, oh yeah, I'm feeling better, I'm seeing improvement. But to actually dive into the data, to apply these scales, there was definitely some things that we were excited and shocked, quite frankly. And I think for me personally, looking at the dyspnea scale and what was potentially driving it was really shocking, but exciting too, that maybe we have. And I think the study that just came out in the UK, or I don't think they published it, but they talked about this, really supports what we're seeing. So we're really excited about getting this paper out next week. If we could go to the next slide, Dr. Bean, and we can look at the next. Now, this is a big one. Fatigue, I think, across the board. I think there's not a single long COVID patient that I think we've interacted. I think over 90%, they'll say fatigue's like one of their top 3 symptoms. So what we did was we applied the fatigue severity score. And this is a score it goes from 9 to 63. 63 being the highest score, 9 being the lowest possible score. And you can look at those numbers. I mean, that is 6 to 12 weeks on Moravrac. And you can see what a strong p-value. This was just off the chart. Just even looking at the raw numbers on the Excel spreadsheet I knew that this was going to be a home run. And very interestingly, again, we are looking at SCD40L, VEGF as markers of inflammation, and also IL-2 and TNF alpha, which we've known in the literature as being implicated in fatigue. Also, TNF alpha has been known to be found in chronic fatigue syndrome to be implicated in that. And look at the p-value on that. That's, you almost have to count the number of zeros.
So, it's really
approaching 0.
Yeah,
and it's from -5.
Yeah.
So we applied the fatigue score, and then if we go to the next one, and this is very interesting. Now, this is the New York Heart Association classification. Any sort of any internal medicine physician is going to know this like the back of their hand. The New York Heart Association, it's basically a classification we use for heart failure. But what we did was we asked the questions of, do you have chest pain? Do you have angina? And interestingly, we also kind of incorporated some of the POTS in there, because that there's some overlap between the cardiac and the autonomic system. The cardiac physiology is controlled by the autonomic. So we definitely included some of those questions into how we ask these patients. And by the way, all the questions were done phone interviews with the patients, with myself and our clinical assistant. And very interestingly, again, we saw a statistically significant decrease in cardiac symptoms. And this was driven by interleukin-8 and GM-CSF. Now, I want to comment on the interleukin-8. Very interestingly, statins are known to decrease interleukin-8. And very interestingly, as I mentioned earlier, that Moravrac, while all the research and all the focus has been on the CCR5 antagonist or blocking HIV entry, it's in the literature that Moravrac has an endothelial or protects the endothelial lining in HIV patients. So there could be a protective mechanism that's taking place, and Moravrac is known to decrease IL-8 too. So we're seeing this sort of possibly synergistic effect with statins and Moravrac. I think the important thing to keep in mind is, this is not a control study. We understand that. This is not we're not trying to talk about drug efficacy, but what we're saying is, look, clinically, we're seeing these signals, we're seeing these objective and subjective markers, and we can overlay that. And now we know what we're going to study. We know which patients are going to respond. We know how they're going to respond. Now we got to put this through a clinical trial, in a double-blinded placebo clinical trial, randomized controlled clinical trial, and then we can understand what we are seeing clinically. Is it truly what we're seeing, or are there other issues and other biases and other things that we need to control? I will say this, and maybe I'm an eternal optimist, and I know Dr. Patterson is too. I think we're very confident that when we put this through a trial, we're going to see some real interesting positive data, because we've been treating so many patients. We know who's going to respond, and we know, unfortunately, who's not going to respond now, because we're starting to get a really clear picture. And maybe this is not the solution for 100% of the long COVID patients, but I'm very confident for a good majority of patients, this is potentially a solution to at least get a lot of their, the debilitating symptoms and get them functional again. And quite frankly, for other patients, get them close to 100%. So I think this is why we're really excited about this paper, because now we're able to show some of the statistical, some of the outcomes and what we have been seeing clinically. And sometimes we want to talk about it, but obviously we can't for patient confidentiality reasons and PHI and the HIPAA rules. But now we can at least get some of this data out there. And hopefully we'll be able to get this RCT up and running, which involves a lot of money. And we're trying to work behind the scenes. Well, obviously we can't talk publicly about it, but we are working behind the scenes and trying to secure funding to run a trial with a major academic institution.
Mm-hmm.
Dr. Bean, am I muted, or is
I think Dr. Bean's muted.
Dr.
I
Bean?
am
You
muted.
you
So
muted
sorry.
yourself. I was sitting
Sorry.
here in awkward silence, going, "Is it me?"
My apologies. So I had this question for you. The question was that, are there folks like FDA or CDC or NIH, are they reaching out, or are you reaching out? This is not a conspiracy theory over here. This is actually science, and it seems like there is potential. Patients are improving as well. Do you have those kind of partnerships in the play?
Well, again, we're establishing those. I mean, I think, seeing articles coming out about what could be done or what should be done in long COVID, and the answer, or our publication just came out, and didn't appear there when it would be a direct answer to one of the questions, is unusual. But all we can do is keep publishing our extensive data, and like I said, we have thousands of patients worth of data, which will just keep us ahead in terms of publishing and publishing and publishing and publishing. But at the end of the day, what we're really trying to do, regardless of whether or not they know now, is when we do a randomized clinical control trial, and we do have control as a company, we do have control over the COVID applications of Moravirac. We're excited about being able to go to the agency and seek FDA's advice on trial design and outcomes, but we'll be coming with hundreds of patients worth of data. We literally, what you just saw in this small case study, we probably have another, I don't know, 200-300 patients that we have the same data on, that we just have to do manually right now before we convert over to a databasing EMR. But the good news is when we go to the FDA, we can go to the FDA confidently that we're using some of the scales that they recommend. We've got biomarker backup on response. So we have both subjective and objective markers, and we have safety data. So we're excited about meeting, with either the NIH or the FDA and explaining our results, because we have so much data, and we look forward to that. Whether it's happened or not as of right now is really, it doesn't matter to us. We have these two papers coming out that'll make a total of, I think, 7 in long COVID and publications, and probably 9 if you include acute COVID. So, I think we have a really good track record of publishing these data, and these two papers were so important. That's one of the reasons we wanted to come on and share that even before we submit them.
And,
Got
and
it.
Dr. Bean, the interesting thing is people think it's just Bruce and me and Osgood and Bream and Kramer and Purvey. With so much, there's so many doctors. There are hundreds and hundreds and hundreds of physicians around the country. It's because again, we don't treat, we don't manage, we give recommendations. We're almost like a data collecting service, a group practice that we collect. We're like the centralized storing all this data, and then we disseminate information. We disseminate research. And it's very interesting, like where the model is very different, but people think that we are treating and we're prescribing. We don't, because we couldn't manage all of these patients. It would be almost virtually impossible. But this collaborative model allows us now to also get feedback from what other physicians are doing. There's a lot of this stuff about the microclots, and I think I think there's some comments about people talking about the microclots. I think it's a very interesting what they're finding. I've been following their research. In fact, I reached out to them and I said, look, our team is ready to collaborate and ready to help out with the microclot team. I don't think people realize that I, made some inroads with them, and they're following what we're doing. But what we believe is that where are the microclots coming from? It's coming
Right.
from the S1, from the CD16 monocytes, irritating, causing a vascular endotheliitis, and that creates a pro-thrombogenic environment that's causing an activation. So when you have exposure of the endothelial lining, you have activation of platelets. Platelets are releasing SCD40L and RANTES. And what are the markers we're seeing right now? SCD40L, and also releasing VEGF. And Novavax is blocking that signaling, that monocyte endothelial platelet access. And again, these are things that unfortunately patients want this immediate drug. They want something that they can take today, a week later, they're gone. It doesn't really work that way. They've been chronically inflamed for 12 to 18, now unfortunately close to 24 months. So it's going to be a little bit of time. I think also the other point is when they get vaccinated, so long COVID patients, they get vaccinated, there's a little bit longer time where they, I think Dr. Patterson can sort of comment on it. It takes a little bit longer for them to clear that S1 protein, which, by the way, it's called the immune subset assay, which allows us now, it's a second biomarker that we can use to monitor therapy. And I think the reference labs in about 2 weeks should have that up and running. We're running that through IncelDX right now. So a lot of patients are getting tested through that. And it's a valuable source of information, especially ones that unfortunately didn't have access to testing. There are patients that they were told they didn't have COVID, obviously didn't get vaccinated, got the immune subset, and there was the S1. And for them, it was that sense of validation. And I think it's a very powerful sort of a psychological tool, that everything that they've been saying is that validation that they've been feeling. And I think that also is part of the healing process too, is being heard. And that's what we've tried to do from the very beginning. We never expected, Dr. Bean, to get this big. We have a very rudimentary EMR system that uses PDFs, like we're back in the year 2000. So we're having to manually have to go through all these patient data. And just even putting these 20 patients together, there's probably close to about 75 to 100 hours of work that went through having to do all the data collecting. So hopefully we get a little bit more resources. And I know Bruce and his team are looking at getting some data analysts that we'll be able to get more of the data that's sitting there. We just can't access it because we don't have the time.
Yeah. So we're converting to a searchable database, so we'll be able to analyze these groups much easier.
So more power to you. This is a lot of important work, groundbreaking work, leadership work at this time, given we have a we have two tragedies happening right now. One is the COVID itself, and then is the fallout. And
Mm.
unfortunately, that fallout, the lingering symptoms for longer time, are happening after COVID or after vaccine. As rare as these can be, but they are happening. So it is not that any of the branches is risk free. They both have risks. What is their percentages can be seen. So thank you very much for your work. Uh, do you have time for a few questions?
Sure do.
Okay, excellent. So I'm going to start. Rima says, so if not brain fog, just tinnitus, worse and better and worse, and lots of congestion, 1 month plus COVID. Is it long COVID? What is it?
Well, by definition, long COVID's 3 months post-infection, but certainly, vascular inflammation is part of acute COVID as well. And so, again, I would just access, our program, www.covidlonghaulers.com, and, we'll address it. And like I said, we've had experience, obviously, with many, many patients with tinnitus. So,
Got it. Next question. Excuse me. Kevin says, is Dr. Patterson curious about how other CCR5 antagonists might work in long COVID and other post inflammatory diseases compared to Maraviroc? He has talked a lot previously about leronlimab.
yeah, again, it's all about a target. And I think CCR5 is an incredibly exciting target. However, Maraviroc's available and it's FDA approved. There's safety studies, 5-year safety studies with Maraviroc. Most importantly, because of Delta and Omicron, there are studies of the safety of Maraviroc in the pediatric population. And that's something I've never seen from any other CCR5 antagonist. And it's something that we need to be prepared for. Um, we've seen it with Delta, but with Omicron infecting everybody and their brother, we're going to need to be prepared for Omicron long COVID in the pediatric population. And for the same reasons, we tend to use atorvastatin, where there's safety studies of atorvastatin in the pediatric population as opposed to pravastatin. So we have to think of that and include that in our thoughts about which drugs and which drugs within a class um, we will use. So I think that's part of it.
Got it. Thank you very much. Dr. Yo, I had forgotten to ask you, what is your spirit animal? You asked that to everyone.
My spirit animal? Oh God, I think it's the brown pony.
I see. So, Louis Valerian says, what has been the longest time a patient had taken to respond to treatment?
I mean, we've had some patients that kind of plateau, then all of a sudden it's as if they fell off a cliff and are all of a sudden better. And we've had a handful of those patients, and I think that's probably around 4 months or so. So yeah, there's some that take a while, but most importantly, what we're doing is that we more than likely see improvement in their uh, objective uh, immune markers prior to that period of time, and I think there's just some symptoms that take a while to clear, especially neuro symptoms. But I think in terms of how we look at it, our first goal is to restore the immune system back to normal. Our second goal is to increase activity and exercise while on medication. If that's well tolerated, we take them off medications. And you know what? That's our game plan for every patient. And yes, there's a wide range of response rates, but when you get a pure population like in our new paper, it was very clear it was 6 to 12 weeks.
And the other
Got
thing
it.
too, Dr. Bean, is we also have to remember a lot of these patients are getting reinfected with Omicron and before that with
Yeah.
Delta. So that definitely, kind of changes the pattern in the picture. That the vaccine changes some of the pattern in the picture, and also the pre-existing conditions these patients have.
Yeah.
So
The reactivation of EBV. I've had more than a few patients I've had to put on, you know, acyclovir or Valtrex, and they actually then got better. So, you know, again, there's a lot going on in some of these patients where we have to be nimble and understand the complete picture. So,
Got it.
And the other thing too, the other point, Dr. Bean, is everyone thinks it's Moravec and statins. You know what? There are some patients, statins and it's low dose prednisone. That's all they needed. So it's, if this were all about just the Moravec and statin, we wouldn't need to be here. We would just say, oh, doctors, just give this and we can go home. Not everyone needs it. There, we've gotten patients better with just a statin and steroid. And then the other point Dr. Patterson mentioned is we restore the immune system, we normalize the cytokines, and then we then treat symptoms afterwards. And there are other things that obviously, it's a much longer discussion that we're looking at as a group. And so I think there's this old thing about it's just Moravec and statin. That's what these guys are doing. Well, we do think it's, greatly benefiting these patients. And then afterwards, we are looking at other modalities and other treatments and collaborating with other researchers and physicians. And the patients in our programs will be the first to attest to that. That sort of close level of integration. On the phone, I'm on emails with doctors all day long. That's what Bruce and I and our team do. That's all we do is we talk to doctors and
And
we just say, okay, let's look at this, let's look at that, let's look at all of these other things too. And we're trying to get a better understanding. So I don't, because I think it's a very complex syndrome that we're dealing with.
I can vouch for that. Both of my family members who went to the doctors in your group, and by the way, they had actually tried I Recover first. They actually recovered with I Recover, and then when the relapse occurred, then it became difficult and it was refractory. And then both of them did not need Maraviroc. They had one more drug added by your group, and then the remaining was still I Recover.
mhm.
The point is, as you're saying, it's not necessary that it's just Moraviroc all the time, but it's really case to case and
Yeah.
how to manage it.
And that's why we do the cytokine profile. The one slide I didn't send you is we have a color coded slide that goes through which drugs lower which cytokines. So, and we have a choice of maybe 12 drugs. So, we have an armamentarium of things that we deploy, but certainly, Moraviroc and statins is our bazooka for people who, you know, obviously aren't getting better.
Got it. One more question. Ryan says, have you heard of kids getting PNS after COVID? And are you treating it the same as classic long COVID?
Yeah, I have a lot of personal experience with PANS and Panda, and it's a very very difficult condition to treat. A lot of it is autoantibodies that go through the blood-brain barrier. We have because Moraviroc crosses the blood-brain barrier, and atorvastatin, is something that is the statin that crosses the blood-brain barrier, probably a little bit better than prevastatin, but it also crosses the blood-brain barrier. Someone with PANS and PANDAS, and I've treated those aside from long COVID, but use something like Moraviroc and atorvastatin, for instance, with maybe even some low dose steroids.
Got it. So this is an interesting one, very specific to the incels work. Can you please explain the process of blood collection and results with incel?
Okay, so again, I want to clarify because it's been misrepresented in some publications. IncelDX doesn't do any testing. What little testing we do, it's for research use only, and it's for us to develop the tests that eventually go out to the reference labs. So really, when you register at www.covidlonghaulers.com, the next contact you'll get is from the reference laboratories. In the United States, that's Innovative Bioanalysis in Southern California, and Radiance in Chicago, and there's probably got another one or two coming up. And then in the UK and the EU, it's SynLab, but IncellDX is not part of that process. Other than we have the telemedicine doctors, we have the nurse coordinators, we have some of the logistical stuff that's part of the website, but we don't prescribe medicines and we don't do testing ourselves. Okay.
Got it. Thank you. Nipa says, and Nipa is actually herself a dental surgeon, I believe. So, dental surgeon, Feb 2020, double vaccinated, had Omicron, role of boosters, still on preventative medicine since April, July 2020. So, role of boosters after this could be my question as well. Got
So
my Moderna 2 doses, then got COVID. Do I need a booster now?
it's all you, Dr. Bean.
Sorry.
You can take that question.
All right. So, in my opinion, the booster is not needed afterwards. And so it depends upon the person's situation, their immune system status, how did they handle it, how long the time, how much time has gone, how much waning has occurred. All those factors have to change. Has the virus changed its variant and has become a totally different thing, and the previous immunity is of no use? All those things would come in together to then decide if the booster is needed or not.
I
My
think the
question.
question that I get a lot is, that I've spoken about in interviews, is a lot of people are saying, well, why don't I just get Omicron and get this broad spectrum natural immunity, which immunologically might sound like a good idea, but the specter of long COVID is exactly what we're talking about here, is the one thing that would weigh heavily against doing something that kind of off the beaten path. And again, we have seen so much suffering from COVID long haulers and post-vax long haulers. It just it's gut wrenching, and that's why we're in this, is to hear the stories of recovery, to get these patients better. This isn't a big corporate play. This is about developing ways to get people better. And frankly, being on the corporate side, it allows us to disseminate information and bring things to market much quicker than if we were an academic and had to deal with some company. So I think that's our mantra. And like I said, we wouldn't work 24/7 every day of the week like we have been if it wasn't about the patients and getting the patients better.
Makes sense. And thank you very much for your work. Um, as I say, which this is a proverb that no good deed goes unpunished. I know that everyone who is working has gotten pushback or heat in one way or the other. You are no exception. But thank you very much for your work and thank you for persisting and continuing. I think that is the only way to move forward, is to
Mm-hmm.
continue to work regardless of the heats and pressures. A couple of more questions. John Snyder says, do you want the new Flurona vaccine? So there is a proposal to combine the flu vaccine and the COVID vaccine or SARS-CoV-2. Do you have any
I,
comment on that?
again, then you're dealing with yearly antigenic drift with influenza, in addition to whatever you want to do with new variant vaccine constructs in corona. I just think it wouldn't be the way I would use resources. So,
And my opinion is, and Dr. Yu, I'm sorry, I think I should send you some questions as well. So my
No, I
opinion is,
enjoy this. I'm enjoying the discussion. This is great. It's almost late in my
thank you.
part of the world.
So My opinion is that the flu vaccine is something that has been out there for some time and we understand what to expect from it. COVID vaccines are still early, we are still discovering a lot of outcomes of them. So, the more they stay separate, the easier it is to pinpoint and identify which vaccine did what instead of combining them and now we do not know exactly what happened. So, I think keeping them separate would be interesting. Frisco Coupon says, are they seeing many cases of long COVID from individuals who had a successful vaccine experience who then later caught the virus?
The answer is yes. I mean, we've seen that. I mean, we've seen probably just about every combination you can think of with the thousands and thousands of patients that we've seen. So, yeah, we've seen that. And like I said, we see different combinations every day. And like I said, Delta showed us a surge in pediatrics. Omicron's going to show us a surge in pediatrics, and as well as everybody else under the sun. So we're getting ready to scale and make sure that we can handle all the additional long haulers.
Got it. Connor Kingston says, when will UK labs open? Will we be able to have the immune subset test as I caught it before testing was available?
Yeah, well, I mean, we're actually our physician network in the UK is actually seeing tested patients as we speak. So again, I think it's a matter of getting the word out and steering people to the right places to get blood draws, etc. But I think SynLab's going to adopt because it's so well developed. I think they're going to adopt the same mobile phlebotomy strategy that we've adopted in the States that has allowed tremendous flexibility. So, we're working as hard as we can, as fast as we can in the UK and the EU.
Got it. Thank you. So, Mark Rice says, where do 3CL protease inhibitors fit with long haulers? That's an interesting question. Any
Well,
takers?
yeah, again, for me, I frankly I don't think there's active virus in long haulers unless you're right at that 3 month mark. We published a paper that showed active replication at 87 days. But I think when you're talking about people who've had it 12, 15, 17 months, that we did find RNA in the paper that came out a week ago, but we did whole genome sequencing, not PCR, which can look at small fragments, or in situ hybridization, which can look at small fragments, or worst yet, immunohistochemistry, which looks at protein. We did whole genome sequencing to see if there was replication competent virus, and we couldn't find it. So, and now we've got tissue biopsies we're grinding up and doing whole genome sequencing as well, just to make sure.
Got it. Thank you very much. So, this is an interesting question as well. Steve Z, is it common to see the T and B cells suppressed in long haulers?
Great question. About 25% of long haulers have decreased CD8 counts. And I think that's why we see a fair amount of Epstein-Barr reactivation, herpes reactivation, varicella or shingles reactivation. So yes, CD8s are affected. B cells are actually increased, and that was in our first paper. And the intermediate monocyte subpopulation was slightly increased in the first paper. But the T cell subsets, the CD4 CD8 ratios are altered by these low CD8 counts in some individuals.
Got it. Thank you very much. Um, One more question. Kayla says, and there are tons of questions. I'm just trying to figure out which one would be more broadly valuable as well. Kayla says, can Quest Labs be used in the US?
So here's the thing with quantitative tests, and I don't care if it's PSA in men or CA 125 in women for ovarian cancer. you do a quantitative assay, you need to do it at the same laboratory because every single laboratory is going to have different technique to do the particular marker, and every single laboratory is going to have a different normal range. And like I said, the labs that we've established with the particular reagents that we developed also use have a license to use our AI to analyze the data. So I think that's also critical.
Got it. This is interesting. So, Red Hot says, what is the diagnostic criteria to classify someone with long COVID apart from symptomatology? So, is there any lab diagnostic scheme that has become acceptable
Well,
or
that's our first paper. Our first paper on machine learning was exactly that. We developed a long hauler index, um, which has proved now, over time to be very accurate in detecting long haulers, as opposed to someone who has acute COVID. And actually, there's a figure down below, which shows long haulers relative to acute COVID. And then obviously, now that we have more MECFS and post Lyme and keep going down. Post Lyme, I think the last figure, yeah, is the dot plot.
keep going?
No, go up a little bit. Yeah, I think that's the dot plot, right? Right
This
there.
one?
It's hard to say. Well, yeah. So yeah, obviously it showed the different scales, and then the yellow in the lower right hand corner is long haulers. Upper left is normal patients. Upper right is mild to moderate, and down in the lower left are severe COVID. What's interesting, and we haven't pursued it, although now that this new paper is out, we might. But see, there was a few of the severe long COVID patients who registered on the long hauler score. And we wonder what's unique about those individuals and whether or not they were on their way to becoming a long hauler. So, but yes, that was the whole intent of this first paper, was to provide a immune signature for long haulers, and I think it's held up against these other conditions like post Lyme and fibromyalgia, MECFS, which don't register on the long haul index.
That
But
is some beautiful work. Thank you so much for doing it. That is some beautiful work. Um, so ZZ Berman says, what markers do you look at for exercise intolerance, and when do you recommend returning to activity?
so, like I said, our plan when we treat a patient is again treat in collaboration with their primary care physician, is to get restore their immune system back to normal, start increasing their activity and exercise. And frankly, if their body pushes back, they need a few more weeks on therapy. But if they tolerate that well, then we start making plans for tapering them off drugs for good. So that's our part of our game plan.
Got it. So one more comment. John T says, can I donate my pittance of money I have left, not just to Dr. Bean, but Dr. Patterson? And I'm so sorry, what is the other dog's name, please? Dr. Yo. So
we
thank you very
we we
much.
could we don't really need money. We all have full-time jobs, but what we need is, if people want to, and I'm joking when I say it, if they want to donate their time to be research assistants and help us do some data collecting, I sure as hell could use the help here.
Yeah.
But we're
Got it.
sitting on a ton of data, but we just don't have time with all our clinical work to do it. But we're getting there.
So I know that it's almost 2 hours. You had actually joined me half an hour before we went live, so it is 2.5 hours for both of you. And Ram, you are on the East Coast, so it's pretty late. Um, Bruce, you are here on the West Coast, correct? So, quick question for you: fluvoxamine, is it more used in your
Yeah,
therapy?
we still use it. Um, like Ram said, if there's some long haulers who, in the spectrum of long COVID, are doing fairly well, and we just want to, normalize a few cytokines, we'll put them on fluvoxamine and statins, which is a very good combination. And there's actually great papers on the use of fluvoxamine in acute COVID. So, when we have friends or family that have acute COVID, we jump towards fluvoxamine and statins.
Got it. So,
And
thank
and
you.
and
Yeah,
Dr. Bean, I just want to mention, someone mentioned about fluvoxamine. There's the cost of Monovax, and we understand that. Bruce and I, our team, we don't control the U.S. healthcare system, and we're trying to navigate through that and the challenges behind that. And we're working on things, and that's why we're trying to get some of the data out there and work with the FDA and some of the regulatory agencies, and we understand it. And so sometimes these things are not accessible to patients, and we work with them on an individual basis. So we're just trying to get people better, and sometimes we have to look at alternative um, options, but then that varies from patient to patient. We have to take into consideration their medical history. And the one term that I cringe is when people start talk about the protocol. Um, or the Patterson protocol, the Incel DX protocol, or the Yo protocol, the Osgood protocol. It's not a protocol. Protocols are that it just basically means there's no thinking going on there. There's a bunch of algorithms and checklists. As clinicians, we don't use protocols. Protocols are not how physicians think. It's an individual basis. It's an individual. You look at lab values, you look at you look at medical history, and you use your clinical acumen in determining what you want to do, how you want to approach that patient. And also, you have to take into consideration financial, social. There's so many other things that come into place that all of us are trained physicians. We're all practicing physicians. So this is like second nature to us. This is not, I think sometimes people think that Bruce just picked up a virology book like a year ago and started reading this, or I stumbled upon clinical medicine a year ago. I'm board certified. Every one of our team is highly trained and highly qualified. So we're able to apply the principles of medicine here. So I want your listeners, the people that are watching this, just to not talk about protocol. Don't think about XYZ and that's it. Or what about this? What about that? It varies. It's a precision medicine. This is how we practice medicine. This is what we're applying.
I mean, what the great example is cancer. I mean, you will not get a cancer drug until you've had a genetic profile of the tumor to tell you what mutations are there and what drugs they may respond to. Um, it baffles me why, very few people that I've come across think of COVID as an opportunity to apply a precision medicine and treat it like we treat cancer, and then we've tried to keep our lab tests that we have in the reference labs and all the other things we do at a reasonable cost. I mean, there's cancer tests that are in the thousands of dollars per test, and we're in the low hundreds. So we've been very cognizant of that, and we've been cognizant of the fact that we're in a pandemic, but it's even more reason for us to do precision medicine on a complicated disease. The fact that we're not patients are being managed in hospitals with a minimum of data is baffling to me, because this is a complicated disease, and we have to use precision medicine to help us decide on how to treat.
got it. Thank you very much. So, a few comments I want to have you read just to be a little happy. We are at the end of the this chat, 2 hours, 2.5 hours for you being here. And I was talking with Dr. Yo before that over the phone. So, Janet says, Honey protocol, y'all. So, that is one. Then uh, there are so many people who just said, tell us how can we help, and we can work. There is a comment that said, we are bed bound, we are injured at this time, so we have time, we can help you. So look at the generosity of people and the willing to continue to help others while they themselves are suffering. And then look at this. Anna says, is there a way to donate to help patients afford the expensive medications? So I would actually request you to, if there is any answer for this, it would be great to have it. Is there any such?
There is a group that's not affiliated with us that we can try to figure out a way to get them in contact. They're sort of helping. Um, I don't really know any of the details, but I know that some group of patients have gotten together just to help out, and they had some resources. And the other thing too, I think people need to realize is our group does a lot of, we understand there are patients that lost their jobs, there are patients that are on Medicaid, that just are, we sometimes look at these video conferencing, and you can just see their homes are like falling apart and they just look rough. We're not, honestly, we're not in this for the money. If any of us want to do money, we would do what we were trained to do. We would not be going anywhere near this. This is to think that this is some money making scheme or way to make it's there's nothing here. I mean, it's funny what people think, but we want to help people. So we don't want the lab testing. We don't want our consultation. We don't want that to be a finances to be a hindrance. We'll work with you. We'll work with your finances. We'll work with whatever resource you have, and we'll try to pull whatever we can, outside resources or internal resources to help those patients. So,
And
um,
and we'll continue to fight. I mean, like I said, the diagnostic tests are reimbursed. Um, to what extent we're not really sure because we're not involved with that. We're just hearing that they are. The ICD-10 codes that have been set up allow for telemedicine to be reimbursed. The medications is still a work in progress, but one of the reasons we wanted to take control of Moravirac for long COVID and COVID is, to start working on, generic manufacturing so that we can make it affordable for everybody. So um, we work on that every day. We've worked with congressmen, we've worked with senators, we've talked to agencies, we talked to everybody we can possibly talk to about getting additional benefits for long haulers and post-vax long haulers as well. So, and we will continue that fight on top of treating individuals.
Got it. So this is the last question. I'm gonna actually put it to both of you, maybe one by one, if you can answer this. This is a philosophical question. I was thinking about this as well, that there was a time that if you had said after vaccine injury, you would be shut down. So here I think it is becoming more and more accepted that this is happening and we need to offer help. And you are leading this area, you're breaking a lot of ground. So here is a question, and if I can get both of your comment. Question is, where does the narrative go now and what needs to happen? So how do this management evolve? When will, for example, I'm adding to this, I'm adding my questions to this. When will, number one, mainstream agree that there is a problem? When would this become reimbursable? When would these patients become recognized? When will this whole structure be put together to start helping these patients? Where do we go from here?
Well, I mean, I think this is a great question, but uh, when I look at the field now, people are just now saying there's this thing called long COVID, almost like Ram said, 2 years or certainly a year and a half since we started working on it, and there was nothing, and patients were being ignored. I think the same thing will happen as information on post vaccination long hauler symptoms gets out there. That you know, here's the data. I mean, it's not about which side of the aisle you're on. It's here's the data. The vaccines are providing what I call a get out of death free card, and but our data also suggests that there's, some side effects, which gladly we can treat. So, the narrative is we got to keep publishing, publishing, publishing. It's all about data. It's not about rhetoric. It's not about long discussions. It's about credible, peer-reviewed data to get out there and say, just like COVID long haulers, like post-vaccination long haulers, even post-Lyme, here's the data, and you know what, the landscape is changing because I think we're starting to understand it. I've always said, as much as HIV drove the molecular revolution in medicine, especially in the cancer space, COVID's going to drive the immunologic revolution in medicine. We're going to come up with more sophisticated ways to look at immunologic disease. We now have a proteomic instrument that is going to be instrumental in defining what's causing all these conditions. And, our goal is to get all of that data out so that people can recognize where there is a problem and we can jump on it, regardless of, what, what the rhetoric is. It's data, 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 data. And you know what? There's a problem. We'll fix it.
Got
I
it.
think
Thank you very much. Dr. Yo, same question to you.
I'll just echo quickly what Bruce just mentioned, and I agree 100% with what he said. I think the important thing when we're talking about any of these issues is we got to be able to say what is hypothesis and what is a theory and what is, as Bruce just mentioned, data. And what we're talking with the discussions or for the past several months about any of these controversial topics, especially with the vaccine, is there's been a lot of theory and hypothesis and people looking at epidemiological trends and trying to make trying to make inferences based on it, and that's all well and good, but that's not our purpose here. We're trying to, everything gets politicized. That's the reality of how, every day we're all kind of witnessing all of that. Any stance you take gets attacked from the other side. And we're just trying to say, look, we've got data. We're not, as Bruce mentioned, we're not talking about epidemiological data. We're not talking about prevalence. We don't know. We don't know. We can't even say. People ask us, well, how many patients do you see? Well, it's there's a bias. These patients are coming and seeing us, so they're not. I can't say if it's 1%, 10%, 0.0001%. I don't know. But what we are trying to focus on is get the message out that, look, some patients are having issues. We think we have a way to treat them and to treat them today. And one of the things I'm a clinician, in my soul. I love the research. It's great, but I don't want to sit there and research for the next 20 years. Let's get the research out and let's see if we can start getting people better today. Maybe that doesn't get them to 100%. Maybe we can continue to research and treat. And this thing about we need to research and have this full thing, that's well and good, but there are people that are suffering. And Bruce and I and our team, we see those patients literally on a daily basis, and we feel for them. But at the same time, when we start to see that these patients are getting better, that's the purpose of us putting this paper out. We're not trying to shut anything down. We're not trying to have a debate. All we're trying to say is, look, we found some signals. There's still a lot of questions to be answered that we, quite frankly, may not have the resources. But we want to work with the FDA and the NIH and government organizations and other healthcare organizations and other researchers. Hey, let's come together. We found this. Let's try to figure this out and let's try to help patients. In the meantime, hey, look, we've got something that maybe could be a solution or part of the solution. Can you guys help us out? And that's our role of our approach with the vaccine. I think if we, we're very confident we take that stance. There'll definitely be some people that will, come out and, say, are you this or are you guys anti-vax? And no, everyone in our group is vaccinated. Most of us are boosted. Everyone in our families are vaccinated and boosted. And as Bruce mentioned, it is preventing death. I mean, there's no doubt about it. But at the same time, there are patients that are having issues and they're having persistent symptoms. Some of them are very severe. And to think of them as collateral damage for the greater good of public health or humanity, it's unacceptable. because that is someone's mom or dad or grandparent or child. Even if it's 10 patients and you say, oh, it's only 10 patients, well, those 10 patients are still human beings and still need to be treated. And as clinicians, that's what we're trying to do, is not get into the numbers game, but rather to get into understanding the pathology and to help these patients.
Got it. Thank you very much. So once again, 8 on the Pacific side, 10 there, 2.5 hours or more we've been together. Thank you very much for doing this research. I think presenting it in a couple of hours is nothing. You have been working on it, you've been collecting the data, you've been writing it, you're putting it together, you're making it digestible for others, you're driving the physicians and their needs. So thank you very much for all that work. Keep on keeping on. That is my prayer for you, because you're helping others. And
Thank you.
for the audience, I think that the formulas that are discussed here, the information that is discussed here, even if you decided that we're not going to work with, let's say, COVID long haulers, or we're not going to work with Dr. Bruce's group, you still have so much information here. There is so much contribution that it can put you on the right track towards starting to understand how to seek help and what and where to go for this. So thank you very much for your time, audience. One request I always say, that please like, subscribe, and share. In this video's case, my request to you is this: hold on to the link for this one. If you see that somebody is suffering, and my family, 2 people close to me, it actually hurts me to think that my wife was a rare case and my niece was another rare event. And imagine if we had just left them behind and said, you were rare. So
Mhm.
please keep these links, share them. Don't force people to watch it, it's 2 hours, but share it if you see that somebody needs this help.
Mhm.
So, once again, thank you very much, Dr. Yu, and thank you very much, Dr. Patterson, for being here.
Our pleasure as always, and we really appreciate you opening up the topics and talking frankly about what we're facing in this pandemic. We're all in this together, and sometimes it becomes divided. We saw that happen in HIV, but at the end of the day, I think we all need to come together. Investigators have to come together and stop worrying about who's got this and who's got that and who's out first. But the fact is, we need to have answers to all of this. So, thank you for providing us the platform.
Thanks, Dr.
Thank you
Bean.
very much.
Mhm.
Thank you. And one promise I need from both of you: once your studies are published, I would request one more session with Cool Beans. No discussion of the pathologies and mechanisms and the treatments, just answering questions. I think that would also be
That'd
a
be
very
fun. Yeah, no, we'd really enjoy that. We like doing that. We
okay.
we have
We might
web.
get more members of our team on that because
Yeah,
Yeah,
so I don't start fading off like I am right now. So
I am so sorry, Yo.
no,
Thank you very
it's
much for
great.
being here.
I really enjoyed
only for you.
talking with you. Yeah.
Thank you very much, Cool Beans, as well. I'll see you tomorrow. Thank you for everybody's time. And
Mhm.
please hold on to this link and share with somebody who needs it. Bye bye.